Last speaker is Mr. Jonathan Makanjuola, who is a consultant urological surgeon at King's College Hospital. And the other area where undertreatment has been seen in particular are those men with Black and ethnic minority groups. And Jonathan, I've seen the slides in advance, so I'm really looking forward to your talk, is going to consider this for our next presentation, and then we will be meeting for a short panel discussion after that. So, Jonathan.
Yeah, can you hear me? Thank you for the opportunity to present. I'm just going to get my slides up. Can you see the slides?
Yes, we can.
Perfect. So my name is Jonathan Makanjuola. I'm a consultant urologist working in King's College Hospital near Brixton in South London. And I'm going to be tackling the very complex issue of how we reduce variation in access to treatment for all men and experience of Black and ethnic minority groups. So COVID's been a great leveler for us. It's blown open some health disparities that we may or may not have appreciated in the NHS over the last 2 years. And even NHS England commissioned various reports looking at the health disparities in COVID between certain racial groups. So this is something that, and I'm personally working on this within COVID as well and other areas. And it's not a day that goes by without seeing news headlines like this, where we see ethnic minority patients in the NHS experiencing health disparities, be that in maternity or in the COVID vaccine uptake, or in access to surgery post-COVID. And this is a nice informatic done by the Race and Health Observatory, looking at different racial groups and various health inequalities in prostate cancer, which I'm going to discuss today, hypertension, mental health, pregnancy and maternity services, and diabetes. So this is an area that is being looked into more by Public Health England, and one that we need to look into and try and challenge and tackle. So health disparities in prostate cancer. It's been known about for many, many years. Even as a medical student, we always knew that Black people had increased risk of, or Black men had increased risk of prostate cancer. And there's various reasonings about that. A lot of the big studies were done from the United States. And we always thought in the NHS, being free at the point of need, this disparity was an American problem. Well, I tell you not. With this paper here, this is a recent paper published in JAMA, looking at 1.5 million men and access to MRI scan for men with PSAs above 7, above 4 or 10. And they found that racial and ethnic factors influence which patients with a raised PSA receive the MRI scan and recommended improvement in decision-making process and address these disparities. More worrying, men with PSAs of 4 or 10 were 24 or 35% less likely to undergo MRI scans compared to white patients in America. And they said that they cannot really conclude the reasons for this was an issue that the physicians were not referring these men for the MRI scans, or these men were declining MRI scans, or was it a financial implication or something in the middle? And again, they've said we need to look into this. So there's been multiple papers over multiple years saying there are health disparities. We need to look into it. And I think now's the time where we need to take some serious action and start really questioning the reasons behind this. So this is the paper published by the group, many of them on this call, looking at determinants of variation in radical local treatment for men with high risk or locally advanced prostate cancer in the UK. And I'm just gonna, Matt's done a very detailed analysis of the paper. So I'm just gonna pick up some key issues with respect to race. And the conclusions were that we know older, men with more comorbidities, socially, economically deprived, or Black ethnicity were all likely to receive, less likely to receive radical treatment. And they said that the variation in treatment in prostate cancer, with respect to ethnicity and socioeconomic deprivation, has been shown in the American system, but prior to this had not been demonstrated in a UK English NHS system. So what are the suggested reasons? The authors say it's unclear why this variation occurs, and they suggest a number of factors such as quality of healthcare environment, resources, patient understanding, patient choice for this. However, I think we can delve a bit deeper into this and look a bit further. Are there patient factors? Why are some groups making alternative choices? Is it an avoidance of treatment? With COVID, were certain groups fearful of coming into hospitals compared to others? Access to GP, as we've alluded to before, could have been an issue. Some delayed getting of a PSA blood test, and then further delayed treatment or presenting with more advanced disease. And again, we know that's linked to social deprivation and access to GP. Or are there staff factors? And I know this one might be very controversial, but is there a lack of cultural or social awareness by healthcare professionals? And this could be a reason why there's non-compliance in these groups of patients. Or is there something else going on? And I'm going to put this word up here. I know this is a divisive word, institutional, but is there institutional NHS issues? So this is a recent study by Workforce, Race and Equality Standard data, looking at Black and minority staff that experience discrimination at work, clinical and non-clinical. And we see significant levels of reported discrimination from minority versus white workers. And if you've got happy staff, we know you have a good NHS care. And this is not specific, but these hospitals were taken at random. And it's interesting, they're all actually major teaching hospitals in metropolitan areas where they looked at certain indicators, such as a percentage of staff who report harassment or bullying, and the percentage of staff who thought there was equal opportunity to career progression in the last 12 months. And we saw there were significant differences between Caucasian and white members of NHS and the minority NHS. So I guess what I'm driving at is if there's not diversity within your staff and equity within the staff, how can there be equity and diversity within the patients we serve? Is this a urology problem? So this is a slide I've taken from our Bowes Endo-Urology meeting last week, where they looked at ethnic and minority representation within prostate cancer specialists. And in 2 years, there were no female prostate cancer specialists that gave any talks in our national association on prostate or bladder cancer. And that was a quite surprising slide for me. So solutions, I'm not here to kind of complain and say things are all bad. How do we improve the situation? I think we need to prioritize research in these outreach schools. For years, we know that Black patients at increased risk of getting prostate cancer and developing higher risk prostate cancer. But if you look at the major trials that have changed practice over the last 20 years, less than 1% of them recruited people of color. We need more diversity in our principal investigators in trials. So then actually these priorities are looked into a lot more and investigated. And I think we do need targeted recruitment of specific groups for these trials and even introduce the dreaded quota word. I know some people don't like that, but I think in 2022, 2021, where we're still having these conversations, we need to kind of push the agenda a bit further. And in terms of targeted health interventions, this is one paper that showed it beautifully. Published in the New England Journal of Medicine in 2018, they looked at hypertension in Black men and found that, as we know, Black men were at increased risk of non-compliance with hypertension medication. So they actually took the interventions outside the hospital into the men's own environments, and they found that they improved compliance of blood pressure medication when pharmacy-led interventions were done in barbershops. Now, I'm not suggesting that we should all take PSA blood tests in a barbershop, but we need to think differently and outside the box as to how we can improve the situation. So I think we need monitoring of MDTs. Is there a situation where there's like-minded individuals making treatment about patients that haven't met? Is there a role of conscious or subconscious bias? We need to improve the understanding of cultural difference and understanding to wellness. And we need targeted interventions to help men understand their disease. And I'll give you an example. In South London, there's a group called Brother to Brother, Man to Man, which is a prostate cancer group for men. And this was set up to address the lack of Black male support groups in a traditionally white dominated area. And they did a survey and looked for reasons why these groups were just not engaging. And there's quite some surprising comments, like some men didn't like the fact it was called a cancer group, or the fact it's held in a hospital environment and not in a different location. A lot of the men said that there was not many people that looked like me running these sessions, and I didn't feel the need to discuss, and I couldn't discuss alternatives without being shut down by doctors or nurses. And the most heartbreaking one for me was they didn't feel that no one had their best interest at heart. Makes me feel, is there a lack of representation amongst staff in looking after some of these groups? One thing that could help is can technology help? So I'm a PI for a prostate cancer artificial intelligence decision support tool, looking at streamlining and compliance with the MDTs. We've been given £2 million to look at this. And the question is, can AI reduce the variation in clinical performance and patient outcomes if we level the playing field? And it's a strong team of technologists, surgeons, and including Prostate Cancer UK. This is a design that we're working through, and the trial starts next year, so watch this space. And finally, regarding representation, we've recently published a video looking at this area. I'll just show you a short snippet. Okay, that's not a problem. Maybe I'll put a link for others to look at the video later on. Many thanks for allowing me to speak.
Hello, I'm Chidi Molopu. I am a urologist and I specialize in uro-oncology, prostate cancer diagnostics, and robotic surgery. I am concerned about prostate cancer in Black men because Black men have twice the risk of prostate cancer than men of other races. Also, the cancer tends to be diagnosed later for a number of different reasons, and it tends to take a more aggressive course. I would like Black men and other men at higher risk of prostate cancer to get checked as soon as they turn 45. See your doctor and discuss prostate cancer testing. This message is for Black men and other men at higher risk of prostate cancer.
Hello, my name is Dr. Leke Oyedotun. I'm a GP in Lincolnshire. I also lead academically for First Fives in Lincolnshire and GPs as a whole in GP education sessions. This message is for Black men and all men who are at risk of prostate cancer. It is very important that you get tested, get your PSA test done, especially once you're over the age of 45. If you have a family history of prostate cancer, take it seriously. If you have any symptoms that you're concerned could be pointing towards prostate cancer, speak to your doctor. Anything like blood in your urine, okay? Anything like an increased frequency, talk to your doctor, okay? Get assessed, get examined. Again, this message is to encourage all Black men and other men at a high risk of prostate cancer to get tested.
My name is Jonathan Makanjuola. I'm a consultant urological surgeon working in London. Please, this is a message to our Black brothers. Think about your PSA blood test. Go to see your GP. Ask for that blood test. Get examined, get checked out. And importantly, know those values. Many times I say to guys, you know what's in your bank account, but you have no idea what your blood test values are. So please, do better. Get your PSA check. Know your values. Record them. And please, let's not die in ignorance.
My name is Professor Frank Chinagwundo, MBE. I am a consultant urological surgeon. I have a particular interest in prostate cancer, particularly how it affects Black men disproportionately. For reasons which are yet to be determined, prostate cancer affects Black men in a disproportion of 2-to-1. That is to say, if you're a Black man, you're at twice the risk of developing prostate cancer and indeed dying from it, compared to if you're a white or an Asian man. 1 in 4 Black men will get prostate cancer. 1 in 12 Black men will die from their prostate cancer. There is a blood test called prostate-specific antigen, otherwise known as PSA, which, although not perfect, can give a good indication of your risk of having prostate cancer. You do not need to have urinary symptoms or erectile problems to have prostate cancer. Indeed, most men with early prostate cancer have no symptoms. The disease is curable if caught early. My message is that Black men over the age of 45 should ask their GP for a PSA blood test. The other group of men who are at increased risk of prostate cancer are those with a family history. For example, a father or a brother or an uncle who has had prostate cancer. So this message is for Black men and those at increased risk of developing prostate cancer.